Thank you everyone for being with us today. Welcome to the BRE Collaborative and Fletcher Group webinar, Housing Continuum for People with Substance Use Disorder. I am Amy Etzel, Implementation Manager with the BRE Collaborative. On behalf of myself and my co-host Melina Stott with the Fletcher Group, we're so excited to share this information with you today. In lieu of sort of the traditional networking and introductions that might happen within an in-person setting, we'd love it if people would enter into the chat what county you are calling in from, as well as your agency or organization and your role there. We will be doing some other participation via chat and polls later on in the webinar where we're going to be soliciting some ideas from each other. So keep an eye out for any potential local partners to connect with after the webinar as people are entering in their information. So before we begin, a few quick housekeeping announcements. You are all currently on mute and will be throughout this webinar until after our presentations. We, as I mentioned, would love your participation in some of the polls throughout the webinar, as well as a Q&A portion at the end of the presentation. We will be utilizing the Q&A box to facilitate this discussion at the end. Feel free to enter questions at any time during the presentation. I will also be monitoring the chat box, although mainly for technical issues. So do ask your questions into the Q&A box, and then if you're having any other technical issues, put those into the chat box. Just a reminder again that this webinar is being recorded. I will be sending all of you a link to the recording of today's event and a copy of today's slides before the end of the week, as well as some other resources that might come up. And then again, a reminder, we built in some audience participation polls, and so we'd welcome your participation in these. Okay, let's get started. I'm now going to turn it over to Melody Pizzolt, Section Manager with the Division of Behavioral Health and Recovery at the Healthcare Authority. Melody has been presenting in now 3 webinars with us around housing and other resources for SUD populations, and we're really excited to continue learning with her today. So welcome, Melody. Thanks so much for being with us.
Thanks so much, Amy and Melina, for the opportunity to share information. I am going to actually take myself off of camera because I am in a rural area, and my bandwidth sometimes, especially when presenting, may go a little computerized. So I'm going to go ahead and take myself off camera and just give you a little bit of a glimpse of who what I look like, so you have a picture to the words that are coming out over the internet. So thank you again so much for your interest in how the state, the Healthcare Authority, is really trying to create a housing continuum for individuals with substance use disorder. And hopefully this is a little bit of a housing 101 as well. Housing's complicated. It sounds really simple. Let's just get people into housing, but it really is challenging in terms of creating what we call the 3 legs of the stool. And so hopefully today I'm going to give you some resources and information of that the Healthcare Authority is implementing, and some additional information around just housing in general. And so hopefully this is really meant to be informational, educational. Please feel free to ask questions, and look forward to receiving your guys' input on, I think we have some opportunities for you to give us input and ideas about what else needs to be created in terms of this expansive continuum. So just a quick review of what we hope to cover today is, why is the Healthcare Authority and the Division of Behavioral Health and Recovery getting into why are we paying attention to housing, and just a little bit of background around that, and some of the outcomes that housing supports and services do to improve health outcomes and behavioral health outcomes. We're in the process of launching a new project called the Discharge Planners Toolkit that we also hope to be very helpful to helping people discharge from inpatient behavioral health settings, hospitals, jails, prisons, youth facilities, foster care in the future. And so I'll do a little bit of a walkthrough over this, our pilot of a Discharge Planners Toolkit. And then last, I'm going to do a little bit of an overview of DBHR's housing projects, as well as our efforts to improve the processes to better connect people to housing resources. And so, that a lot to cover this morning. One of the things I really always like to to start presentations off with housing is this slide that that talks about this housing first, or this photo voice project that we did with a couple of, whoops, my computer is starting to jump around. So the photo voice project, if you've not heard of photo voice, it's really a very cool quasi experimental qualitative study where we give individuals cameras and ask them to record what their life was like before an intervention and what their life was like after an intervention, and then put those pictures, ask them what was the significance of this picture, and in your words, and why did this make such a difference? Why did housing make, in this case was a housing intervention, make a difference in your life? And I really love this picture, and there is actually a video, and there's a hot link in the slides to the results of some of the photo voice projects that we've done, as well as a video on photo voice. But it really also reminds me to check my values and my because my values on what housing looks like, and the it could be very different than the participants that we serve. And so, I wouldn't necessarily, from my perspective, from my middle class perspective, see this as a robust garden. But to this person, this garden was really incredibly meaningful for her to have a house that had somewhere that she could do some gardening. And so I think that's something, it's just a good checkpoint for me to really check my values at the door, and that really paying attention to what the needs of the individuals are. And so the photo voice really just helps do that for us. So why has the Healthcare Authority and the Division of Behavioral Health and Recovery paying attention to housing? And this report that Research and Data Analysis did a couple of years ago really speaks volumes about the need to better connect people out of inpatient behavioral health settings with housing resources. And what they found was that almost 30% of people coming out of the state hospital had a housing need in the year after discharge. So, that's pretty significant when you consider the costs associated with inpatient settings, especially in the state hospital. And then also, almost 50% of people coming out of substance use treatment programs needed housing in the year following discharge, and a very large percentage of them discharged to homelessness. And so it's pretty staggering numbers. And so the report took another step further and said, how many of those folks coming out of those inpatient settings, state hospitals, and substance use treatment programs got connected to the homeless safety net system, which is what's known as the Homeless Management Information System. That's their data system for housing and homeless services. And what they found was that very few individuals are getting connected to the housing resources in the homeless safety net system. About 18% of individuals leaving substance use treatment programs were getting connected to the homeless safety net system. And so how do we do a better job of connecting people to those resources? And so that's one of the things that we've been trying to do over the last several years, is develop a better bridge between inpatient behavioral health settings and community resources. And those numbers are a little old. The report is a little old, but I don't think that they, the anecdotal information that we have received are essentially that these are still challenging times to get people connected, especially as we see homelessness increasing. So it's also really starting to see, we're, as the healthcare authority, we're really starting to pay a close attention to the social determinants of health. What I call the hurricane of change that we went through in 2016 as we moved mental health and substance use treatment services into integrated managed care. That hurricane of change was really about starting on this path of whole person care, that paying attention to an individual's primary care issues along with their mental health and substance use was really important in order to serve the whole person. Now, I think we're taking that one step further, in that you can't help somebody's primary care or behavioral health conditions if that person is still homeless, if they don't have good nutrition, if they don't have transportation to get access to services, if they're unemployed. And so those resources, those social determinants of health that really help us take that whole person care approach really one step further, I think is really important.
And Melody,
so we've actually been doing
Melody, we were going to do our poll now, just to kind of think about, just as a reminder to think about the housing as a social determinant of health. We were interested in hearing from the group who currently is tracking housing. So I'm going to launch a quick poll. And then for those of you, oh, go ahead.
Oh, please, go ahead.
Just really quick, for those of you that are tracking housing, so those of you that enter yes, we'd love to hear from you in the chat, just a quick blurb of how and in what way, because that might solicit some ideas for the audience and potential, as I mentioned at the beginning, potential ways to connect locally if you hear a good idea from a local partner.
That, you know, as you're also thinking about housing status, and actually there, as part of the hurricane of change, there was actually a law, two laws passed in 2013, excuse me, Senate Bill 5732 and House Bill 1519, that actually requires the behavioral health system and the healthcare system and the long-term care system to track outcomes. And for the behavioral health system in particular, the housing and employment outcomes are specific measures that are being tracked from managed care, from the BHASOs. And so those dashboards are actually available on the research and data analysis site. So if you want to know how are we doing around our outcomes of helping people obtain employment or reducing homelessness, I will get the link to those dashboards and put them, send them to Amy so she can distribute them. But that's something that, you know, tracking those outcomes, I think, is an important part of our service delivery system.
That'd be great. If you email them to me, I can share them when I send out the slides and the recording. Thanks, Melody.
So it looks like about 27% of folks do track housing status, and 73% don't track housing status.
And then Melody, it looks like we have a participant on here who started tracking homeless numbers as part of a project through the MTP. Is that the Medicaid Transformation Project, I assume?
It is. That would be the 1115 waiver, yes. Those social determinants of health, yes, absolutely. It's important to, you know, again, it is all related to that whole person care and paying attention to the social determinant needs of that person's health. All right, I'll keep moving forward. So as part of actually the Medicaid Transformation Demonstration Project, and I'll talk a little bit more in the later slides about this, but we are actually using the 1115 waiver to demonstrate, do targeted interventions like supportive housing and supported employment have an impact on the triple aim, you know, improving individuals' healthcare satisfaction, decreasing costs. So that is all part of the 1115 waiver, but we are seeing initial results of the 1115 waiver and seeing reductions in emergency room visits and inpatient hospitalizations for people receiving supportive housing services. So we see some very positive direction around these interventions of supportive housing, helping somebody to obtain and maintain housing. So those are some really great resources. And one of the reasons why we need specialists and a dedicated service helping focus on obtaining and maintaining housing is because it's complicated. There are so many different, and I call them funding trickles. They're not funding streams, but funding trickles to help somebody navigate when they are experiencing a health crisis or a behavioral health crisis is really challenging. And so it is so, there's federal resources, there's state resources, there's local resources, and where do you go to try and find the kinds of supports that you need with what kind of housing it is. And again, I also think that there's a little bit of a paradigm shift in how do we match people to the right supports and housing environment that they need to be successful. I think historically we've sort of said any housing's good housing. And I think what we're learning is that really what we need to do is really match people to the kind of environment that they need to be successful. And so that also adds a layer of complexity in trying to help somebody navigate all of these different types of housing, the different types of services, the types of housing subsidies that are out there. Those are all sorts of wonderful acronyms. They speak their own acronyms in the housing world. There's publicly funded project-based housing, and there's also different kinds of residential treatment types. So trying to find the kind of level and support that that person needs to be successful, while also trying to increase that person towards rights, privacy, and dignity. It's really about trying to help that person in the environment that they need to be successful. I'm getting a nice little notice that my internet is unstable, and hopefully I'm coming across clear.
You sound great. Thanks, Melody.
So one of the projects that we are trying to develop to help discharge planners in particular with these resources is what's called a Discharge Planners Toolkit. And what we're really trying to do is harness all of this information, because again, it is complicated, into being able to ask a series of questions, providing some tools and resources in a structured manner that helps better connect people in inpatient settings to the resources in the community. And so that bridge is part of what we're trying to do with the Discharge Planners Toolkit. We have a multi-state system approach to this. So we're working very closely with the Department of Commerce, Economic Services Administration, Aging and Long-Term Care Services Administration, the Department of Corrections, the Department of Children, Youth, and Family are all part of the project team that have worked on helping develop this Discharge Planners Toolkit. So our first process, it's really kind of this three-prong approach. We want to create this sort of electronic decision tree to help better connect individuals to the right services and resources to help them obtain and maintain housing. And then we want to actually give individuals that are in those settings a tool that they can take with them when they're discharged. And the third is really about, nothing's more frustrating to, I think, a discharge planner to hear about this great program, make a referral, only to have that program rebuff the referral. So we're really doing a lot of work to cultivate the soil at the organizations that are going to be receiving these referrals from the Discharge Planners Toolkit, so that they can actually, again, build that better bridge from the discharge to the resources in the community. So the decision tree that we're working on is really about, there's three parts to the decision tree. The first part is really the checklist. What are things that the discharge planner can do to help prepare that person for accessing resources in the community? So we've provided a lot of resources and information, things that they can do while that person's still residing in the inpatient behavioral health setting. One of the key things is actually documenting what their homeless status was before they came into the facility. So that can actually play a big part of connecting somebody to resources. And so that poll earlier is really helpful. If you guys can gather information about where was that person living prior to coming into the facility, that's going to be really helpful and get helping that person get connected to resources upon discharge. Also, your documentation could actually help that person get access to resources as well. The second section of the decision tree is really about, again, that paradigm shift and really thinking about what kind of environment does that person need to be successful. And so we've provided a lot of information on the different kinds of environments. And again, this is really just an educational part of the decision tree, but it's really about prompting you to have that discussion with the individual and what does that person need to be successful, and really what is their choice in housing. We know from actually research that when we give people choice and power and control, they actually are more likely to be successful in that environment. The third part of the electronic decision tree is going to be the skip logic that hopefully gets you better connected to the best housing resources upon discharge. And so it walks you through some of those different programs and resources. So that's also a part of the electronic decision tree. Our first step is that we're going to pilot this at some mental health crisis stabilization facilities and some substance use residential treatment facilities, as well as we actually just recently, as part of the 1115 waiver, received approval from CMS to begin providing supportive housing services in short-term IMD, or if you're familiar with that term, what are called institutions for the mentally diseased. It's a very archaic term, but it basically means agencies that have more than 16 beds where the predominant treatment services are mental health or substance use treatment services. And so by allowing our FCS program to start beginning those housing plans prior to that person discharging, we think we can again build those better bridges from somebody moving from an inpatient setting out into the community. And so we're actively working on launching the FCS, both in the SUD world as well as the mental health world, to help bridge and start developing those housing plans. So those are some efforts that we have currently underway. So now I'm going to move just a little bit to talking a little bit about the three legs of the stool and why housing is so complicated. Particularly when we talk about permanent supportive housing and really based on the evidence-based practice SAMHSA model of helping somebody obtain and maintain their housing, really thinking about immediate access to housing, supporting somebody once they're in housing, and making sure that it's affordable, that people aren't rent burdened. And so that approach really takes partnerships to create the three legs of the stool. So one of those legs of the stool is really just the capital to build more housing. We just need more housing stock, just plain and simple. We have a huge housing shortage. I read a report that we are, I think, 169,000 units short of the need for housing for people that are low income in Washington state. So we have a huge housing crisis. We just don't have enough housing stock. And so particularly affordable housing. And according to HUD, the Housing and Urban Development, that really an individual should be paying no more than 30% of their income towards housing. And so and if you think about somebody on SSI, who's receiving $790, we need more housing stock. And so there's a couple of main ways to build that housing stock. So one of the largest ways is through the Housing Trust Fund that the Department of Commerce manages. And so they receive an appropriation from the legislature to build more affordable housing. And those are oftentimes braided with the housing subsidies, because even if you build housing, you still have to be able to pay the utilities and insurance. You still got to be able to replace the carpet. And so you need rents or housing subsidies to be able to pay for those ongoing operations and maintenance costs. And you also want to make sure that there's services wrapped around the individual within that housing. And that really, again, is the permanent supportive housing model. And so one of those challenges is braiding all of these resources together. And one of the projects that I'm going to talk a little bit about in a little bit is what's called the Supportive Housing Institute. The Supportive Housing Institute is an opportunity to actually bring teams of agencies together that are builders, housing providers, service providers, funders, on how do we actually develop a team approach to applying for the Housing Trust Fund. And the substance use population really has not had adequate access to this model of the house through the Housing Trust Fund. And so we really want to try and promote the opportunities for the substance use population. So we'll be launching a supportive housing institute hopefully after the first of the year. And so we're really excited to be able to share resources and information about how substance use treatment providers can partner with housing developers in order to help build these three legs of the stool around individuals with substance use disorders. The other housing subsidies, and as you can see, there are quite an array of different housing subsidies, and I really want to call your attention to two of them that are really actually, well, three of them that are really intended for the, could benefit the substance use population. So housing and essential needs, or HEN, about 2 years ago, legislation actually expanded the availability of HEN to include the old general assistance for the unemployed population, as well as individuals with a primary substance use disorder, and as well as the age blind and disabled population. Now you're saying, well, they ran out of HEN dollars, my population never got access to HEN subsidies. This last legislative session pretty much doubled the amount of what is in the housing and essential needs housing subsidy bucket. So there are significant resources available now to help individuals. And so really encourage you to develop relationships with your local HEN provider. The other one that I'm going to talk a little bit about is our program called Harps, and I'll highlight that program, but we actually intentionally created a project to bridge people out of inpatient behavioral health settings using that data from that I first talked about, and identifying individuals with substance use disorder as one of the primary populations that we want to serve with our Harps program. Another program that I have underlined and kind of highlighted, which is also intended for the behavioral health population specifically, is called our CBRA program. And so it's Community Behavioral Health Rent Assistance Program. This is actually managed through the Department of Commerce, and initially was wrapped around the Harps program. The Harps program was intended to be that short-term bridge out of inpatient behavioral health settings. But what we soon found was that people still needed access to long-term housing subsidies. And so the legislature actually funded the CBRA program, and they came in and provided those longer-term housing supports for individuals with behavioral health conditions. That program went from $2 million this last legislative session to over $11 million. And so there's also significant resources being invested in long-term housing subsidies. So I'll pause and for a second and take a breath and see if I'm need to, if there's another poll or.
Yeah, hey Melody, there's a couple of questions that came in. Miranda, who works, it looks like she's in the Olympic Community of Health region, is wondering, is the toolkit specific to SUD discharge planning or for all discharge, inpatient mental health, inpatient SUD, inpatient hospital for physical issues and behavioral issues, etc.?
Eventually it's going to be for all populations. We're just going to start piloting it in some mental health crisis stabilization programs and some substance use treatment programs. So we just want to try it on for size first, get some feedback before we take it large scale, but it is eventually intended for all populations.
All right, thank you for that. And then the other question that came in was around partnership with local communities to keep things up to date and accurate, citing a barrier that the existing resources in communities aren't always up to date. And so it can be challenging to refer people.
Yeah, absolutely. And I think that every community is required to have a homeless continuum of care. And in that homeless continuum of care, they're also required to have what's called coordinated entry. And one of the, I think there's a link, and I'll make sure, Amy, that you have this link, that there's actually a list on the Department of Commerce website that lists by county, every coordinated entry contact. And what I really always encourage is the sort of the first line of defense is always referring people to coordinated entry. Coordinated entry is intended to be the triage sort of one-stop shop for homeless housing resources in your county. The challenge is that each county has the opportunity to prioritize who they want to target their limited resources to. If you want, as a community, as an advocate, your opportunity is to develop a relationship with your homeless continuum of care to see if you can influence who are those priority populations for your county. And so that is, I think, an opportunity, again, of developing those relationships. There are resources through the Department of Commerce on the homeless continuum of care through what's called the Consolidated Homeless Grant. They provide some guardrails on what those prioritizations should look like. And I would encourage you, again, to be familiar with your local homeless continuum of care, your local coordinated entry, and then also the Consolidated Homeless Grant guidelines, those guardrails, so that you can have opportunities of again, trying to develop relationships with those partners in your community to develop better bridges.
Great, thank you. No more questions currently, and then our poll that we'll do via chat comes a little bit later on in your program.
Awesome, thank you. So the Division of Behavioral Health and Recovery, one of the things that we're trying to do is also really create a continuum to enhance that homeless continuum of care, to enhance coordinated entry, because we know that when you have those local variations, that there are some individuals that don't get connected or may not be prioritized. And so for the behavioral health, with a behavioral health lens, we're trying to come in and sort of fill some of those gaps and work very closely with our local homeless continuums of care. And we're doing that through the SAMHSA recovery support lens. So SAMHSA has identified that recovery really is about focusing on these 4 domains: health, home, purpose, and community. And so as we think about health and really including the social determinants of health, housing, employment, income, nutrition, transportation, we're starting to move in that direction and really see communities understand the importance of whole person care, and that, just focusing on primary care issues or behavioral health conditions is not enough, that we really need to think about housing and employment, particularly, through our foundational community supports. We're able to add some new service delivery to our state, two new benefits to our state, using Medicaid to deliver those services. And so I'll talk a little bit more about foundational community supports. Every one of these underlined projects is actually a hot link that takes you to more information about FCS, as well as some of the other programs that we have. So when you get the slides, you'll be able to go into a little bit more detail, find out a little bit more information about these unique programs that the Healthcare Authority is contracting out through community resources, community providers. So for home, we have several different programs that focus on helping people with behavioral health conditions. So we have our PATH, P-A-T-H, which is Projects for Assistance in the Transition from Homelessness. So this is a SAMHSA-funded project to do homeless outreach to individuals with suspected mental health conditions. And then under the True Blood Settlement Agreement, we took that approach of doing homeless outreach and connection, and we're focusing on individuals that have touched the criminal justice system specifically individuals that have multiple competency evaluation orders, and we're doing targeted outreach and engagement to individuals that have touched or that are potential class members or previous class members under the True Blood Settlement Agreement. Because we see so much value in doing outreach and engagement, and the PATH program was so focused on mental health, we asked SAMHSA through our state opiate response grant, can we expand our outreach efforts to individuals with suspected opiate use disorders or stimulant use disorders? And that is actually our Peer Pathfinder program, that we're actually using people with lived experience to go out and do outreach and engagement to individuals with OUD. Our housing and recovery through peer services was a specific program that we designed in direct response to those data charts that I showed on the first two slides. It was created using the permanent supportive housing model through SAMHSA, where we use peers to deliver supportive housing services. So this is about the services to help somebody obtain and maintain housing, but also we have a bridge subsidy where we can pay for first and last month's rent or deposits, even some furnishings, even arrears if somebody's in an inpatient behavioral health setting, or the thought of going into an inpatient setting because they're at risk of homelessness or can't pay their rent. We can do some arrears in the Harps program as well. And it was one of the first integrated programs that served both mental health or individuals with substance use disorder or individuals with co-occurring. That model was actually so successful that we also have a forensic version of the Harps program under the True Blood Settlement Agreement, focusing on individuals, again, that have touched the legal system or have been ordered to outpatient competency restoration or in the FPATH program. Our Foundational Community Supports program is specifically a Medicaid service that is able to provide supportive housing services to help somebody obtain and maintain housing. And most recently, this last legislative session, we actually were just awarded funds to also help pay for rents. And so we're very excited to add a housing subsidy onto the FCS program, and that's going to be coming out this fall. We also have been legislatively directed to expand recovery residences and Oxford houses. Washington State DBHR has actually been a proponent of Oxford houses and has one of the largest number of Oxford houses in the country, with I think over 350 Oxford houses in Washington State. But we also want to give opportunities for recovery residences, which are private entities that allow individuals that mutual support to help people in recovery. There's sometimes a resident manager that is part of that process. There's also level 3 and level 4, which are a little bit more complex, where there's a little bit more service delivery attached to levels 3 and 4. We've actually created a registry of recovery residences, that first level 1 and 2 and Oxford houses, where you can actually go and see which entities meet some quality standards as part of a recovery residence through the Washington chapter of the National Alliance for Recovery Residences. So that's also some links to learn more about our initiatives to expand recovery residences and Oxford houses. And then we've also piloted a peer bridger program, first with the state hospitals. However, we're working on actually expanding our peer bridger program to also focus on substance use treatment agencies. And we're going to be launching a peer bridger program for people in jails. And the peer bridger is actually a model out of New York, where individuals with lived experience actually go into the inpatient settings, develop that relationship with an individual, and then bridge that out with that person and actually walk beside them as they move from inpatient to the community and stay with that person. So they're the consistent member walking alongside of that person from inpatient out to outpatient. or to the community. And so the Peer Bridger project has been happening in the state hospitals, and we're again launching that in 2 new environments this next year. Our, in terms of purpose, you know, it's so important that people have purpose in their life, whether it's employment or other opportunities, giving back maybe through peer services. So the peer credentialing program is also under my umbrella in Washington State within the division. And so my team actually processes about 1,500 applications, and we on an annual basis credential about 500 peers into services. And so peers can be mental health peers. It's also a Medicaid reimbursable substance use treatment service now. And so we're really excited to see peer services expand into lots of different environments. Supported employment is another evidence-based practice model under foundational community supports. It's very parallel to supportive housing, where we can actually help somebody obtain and maintain employment, really doing that tailored matching between an individual and an employer. And so it's really about, again, helping that person obtain and maintain employment and supporting that person through the whole process. So supported employment and individuals with substance use disorder are one of our target populations for supported employment. And so I don't think that the substance use population have really had access to this level of individualized services through the Medicaid benefit. So this is really exciting. And we're seeing some really good outcomes with actually reducing healthcare inpatient, increasing employment outcomes, increasing wages, and increasing hours worked. We're also launching more recovery cafes and clubhouses, which are both a mental health and substance use treatment model. We're taking kind of a broad view of what a clubhouse is. So they're what we call big C clubhouses and little C clubhouses, really opportunities for people to go volunteer, learn skills, but also you'll see it's also on the community side, because it's really about creating a community. And then Cheryl Wilcox leads our efforts around community recovery support services. And these are funds that actually pay for things that can help that person in their recovery. So if it's about maybe paying for a certification program, books, shoes, tools, application fees, those are things that we can actually pay for under recovery support services. So really exciting and seeing some really promising results. Under community, again, it's really important to develop that community support. And so peer services are one of the fundamental ways, but also recovery cafes and clubhouses are another opportunity. Excuse me. Peer Respites is a brand new service that we're launching in Washington. Again, it's where peers provide mutual support to help somebody that is going through a psychiatric distress, where they can stay in that respite home for up to 7 days. And then we're also expanding peer-run and peer-operated services through Washington. So lots of exciting things happening. I do want to just talk a little bit about some of our process improvements that we're going through. And this is just kind of gives you another glimpse at the homeless outreach programs and the housing supports that we have available, both in services and housing subsidies. But a couple of the things that we're using our block grant stimulus funds to do is to create a behavioral health housing action plan. We know that we have a shortage in housing. We know that we have a affordable housing crisis. We lack housing stock. And that's kind of for the broader low-income population, homeless population. But specifically, what does that look like with a behavioral health lens? And so this is going to take all of that broader information and drill down, what do we specifically need to get more housing options for people with behavioral health conditions in our state? I mentioned a little bit earlier about the Supportive Housing Institute, and this is really a very cool, and I think next month we'll be actually having a presentation from the Corporation for Supportive Housing on their curriculum that they've developed, which again really brings service providers with housing developers and housing operators, and how do we create this partnership to go and pursue funding to build more affordable housing and wrap services around individuals. And so the Supportive Housing Institute is really exciting. We're going to have a couple of cohorts of teams that will go through the Supportive Housing Institute intensive training. It's about a 10-module training event that will launch next year. And just really excited to focus this on the substance use population for this next year and see how we can create some of those relationships between those housing developers and the the substance use treatment community. I talked a lot about the Discharge Planners Toolkit already. We're expanding foundational community supports into IMD settings. We actually are following an evidence-based practice fidelity with supportive housing and supported employment, and we actually incentivize agencies to participate in that fidelity review process. And we've really created a learning collaborative approach to how we implement fidelity. So fidelity is not an audit, it's really a continuous quality improvement approach, and how agencies, I think, really having an opportunity to learn from other agencies is going to help you improve your quality of services rather than us going in and auditing you. So we want to pay agencies to participate in this incentive or in this learning collaborative approach to implementing these evidence-based practices. We also have seed grants available for substance use treatment agencies to add foundational community supports to their book of business. So we have resources to help you. We know it's expensive to add a new service to your book of business. There's training costs, there's hiring costs, getting the right staff, getting them on board, and just onboarding somebody until they are able to deliver services. You're not going to have any money to pay. Your agency is not getting paid. And so we actually have seed grants to help agencies with bringing staff on board to deliver supportive housing and supported employment. Those specialists aren't grown overnight. We have to create those specialists. And so we've created curriculums and tools and resources to help agencies onboard staff, but we also know it's expensive. And so we have seed grants to help substance use treatment agencies. We're also working with research and data analysis on a housing estimator, which is, again, another tool in the toolbox. It's really at the very ground level, at the incubator level, but that Pathways to Housing site is a fantastic tool and resource. The other thing I want to just highlight is that I have 2 supportive housing staff that are trainers. I have 2 supported employment staff that are trainers. That we're here to help you as organizations learn more about these resources, this hour that I'm presenting is really the tip of the iceberg. And we have so many resources and information that we can share to help you be successful with these services. And so we're actually working on creating a training catalog. But those 4 trainers are really available to help your organization move forward, and you don't have to do this alone because it is complicated. And these are some other projects that we have going on. One of the really exciting things is we were able to actually use the 1115 Medicaid waiver to buy cell phones for people enrolled in foundational community supports. So we bought 3,000 cell phones to help people get connected to services, resources, housing, and employment. So those are some really other exciting things. So I'm going to pause, and the rest of the presentation is really about a deeper dive into all of these programs, and we might not have time, and I'll just pause and see if there's questions.
Melody, this is Melena. This is all great information. And I am wondering, through the chat, if folks have had experience with these programs, and, this is kind of your opportunity to give feedback on the needs of your communities, and to the question asked about earlier around working with communities. I think that there's a deliberate intent here to work with communities. And so maybe using you all here today as our audience, how do we do that? How do we reach you? How do we make sure these tools get to the hands that they need to be in?
Are you still there, Melody?
Yes.
Okay, just checking.
I was just gonna kind of slowly scrolling through the rest of the slides, just to see if there's any responses in the chat. Yeah, I'm really interested to hear if any of the agencies on the line, are familiar with, is anybody familiar with Harps or foundational community supports or our PATH programs or our peer pathfinder programs? I'd love to know if you're working with them or if you've heard of them. We actually did intentionally in the PowerPoint slides, when you receive these slides, actually include contact information for folks. I know how important it is when you hear about a cool program to actually then know how to get a hold of them. So, so if you're not familiar with these programs in your region, we do have links and information.
All right, we have someone that says that they start working on housing on admit. Thank you, bless your heart, into our residential treatment program. That's absolutely the need, because if you don't start at admit, that timeline is so challenging. And most of the time, the application process for HEN and Harps takes longer than 28 days. And that's longer than we have an individual treatment. And that is a really important piece. So the Foundational Community Supports Program is a program that you can refer to, and I don't know if you've done that or if all of the folks will meet the criteria, but there is the housing case management and that you can use to transition people from residential setting once they leave, to make sure they stay connected and get access to housing. Although I know that there's many other barriers that you're trying to address as well. At discharge. We have somebody else that says that as a primary care physician, they're grateful for the resources and bewildered by the complexity. And that is absolutely the case. And Melody, maybe you could speak to, some of the efforts that you're doing to connect health and housing services, right? Because of these complexities, and maybe some of the work that's happening with the Healthcare Authority and the and Commerce and the supportive housing institutes as a way to kind of aid people in this process, because it is so complex, and attach the technical assistance and other service providers to support that.
Yeah, thank you. And Dr. Patinos and Dr. Chen, our behavioral health medical director and Medicaid medical director, are very keen into that issue, is how do we give this to primary care doctors in a way that isn't so overwhelming, so much information. I think that's really also what somewhat prompted the Discharge Planners Toolkit, is that ideally that it would be a website that will actually literally walk you through information that you'll be, will connect you to the Harps program. It'll connect you to coordinated entry. It will, it has all of those things embedded in the skip logic that you'll just walk through, and it'll ask questions of, is that person, did that person serve in the military? Because they might be eligible for veterans homeless housing resources. And then it links you to those homeless housing resources. And so we are really trying to think about it in the lens of, I love 211. 211 is a fantastic resource, but it's overwhelming. And if you don't know, if you put in sort of housing resources in 211, it gives you lists and lists and lists of housing resources, which is great, but then you're still kind of navigating to see which one you're eligible for. And so what we're hoping that this Discharge Planners Toolkit will do, and our electronic decision tree will actually talk you through which of the programs that person will be eligible for, and better match you to the resources. So that's what we're really hoping for. Again, it's coming, it's still in development, but we definitely hear you and see it is complicated. And that's one of the reasons why we're trying to consolidate information into smaller chunks that can be linked like within the Discharge Planners Toolkit.
All right, thanks for that, Melanie. I want to address the comment about reluctance on the housing question. And I appreciate that. It's correct. There's not enough housing stock, and as clinicians, it does feel helpless sometimes to support people in that way and not have the answer. I do want to take us back to those slides at the beginning where we talked about, how this data informs priorities and what the state works on. So it's the unfortunate dilemma of we can't do anything without data, and sometimes we don't want to ask the questions because we know there's not something we can do. And then the other suggestion was that primary care is a different world and doesn't always work with discharge planners as a consideration in the development of the toolkit. Melanie, do you have anything else to add as we look here? If folks have any more questions with the remaining 3 minutes left?
I think just, that everyone's going to receive these slides. I'll make sure that coordinated entry, and hopefully you guys took notes on what else I promised to send. But, for example, foundational community supports, we have a link to a referral form, embedded. We've put contact information in here for a lot of these programs. We're also, myself and my team are always open to provide additional resources, questions, presentations, and information. We know that this is complicated, but it's also so important to help people with their recovery. And so there's certainly a lot out there, and we're happy to share any of this in other ways. And again, really appreciate the opportunity to hear from you all and what you think is going to be helpful.
Yeah, I just want to echo that. When I send out the slides and the recording and the resources we've discussed, there will also be a link to a follow-up survey that I really hope you guys participate in, because it will prompt you to answer, what other topics within this very complicated space would you like to learn more about? And Milena and I are really wanting to, we've done a few webinars on this and it's been pretty informational, and we really want to kind of move into that action space of what do we do rather than continuing to admire this problem. And Melody's obviously making waves in this area, and so we really want to hear what else you'd like to think about and talk about together as a community. Anything to add there, Milena?
Just that we're available to outreach and hear your story, and that this isn't a problem that we're going to solve without really good communication and collaboration and partnership. It's too big for any one state agency to solve, and I am pleased to see the amount of partnership and collaboration and commitment that there is to solving this problem, and we can't do it without community input. So we welcome you and others in your community to engage.
Yes. So with that, I think we will sign off. And again, please reach out to Melody, Milena, or myself with any further questions or anything else that you'd like to talk about to continue this conversation. And just thank you so much for being part of this conversation and being with us today. Have a great afternoon.
Amy, Milena, thank you so much for the opportunity.
Great. Thank you, Melody, for being here. Absolutely.
Appreciate your partnership.
Yes.